So I think he's going to tell us about the most important thing in the pediatric cataract or refractive or whatever, even for the glasses when you prescribe. The eye is going to grow. In the first 6 months, every month it's 0.6 millimeter growth. That means 0.6 into 6 becomes 3.6 millimeter from day 0 to day 6 months. So let's see how this help you in modifying your IL powers. And Tanmay, all yours, please.
Thank you, Dr. Kokar. So I will be presenting today on biometry of child's eye. So I have no financial interest. So how to do a biometry in a child's eye? So if the child is cooperative enough, you go ahead with the optical method. This preferred because the results are quite consistent. Now the question is, if the child is not cooperative, how to go about it? So we do what is known as an on-table biometry along with an examination under anesthesia. So what are the sequences of on-table biometry is, first you go ahead with the sedation. Now the agent to be used is what you usually do is leave it on the anesthetist that is giving the anesthesia, followed by keratometry, and followed by IOP with Perkins. Now if we do the IOP with Perkins before the keratometry, then the Myers will come deranged and will give an erroneous readings. So the keratometry, while doing the keratometry, preferably it has to be done without the speculum. So the next is the tube insertion, and then we go ahead with the other examination parts, the axial length, corneal diameter, etc. And then we proceed with the rest of the surgery. So now the question is, what formula the question is what formula do we use? So we have a lots of formulas. The standard but where we use was the SRK2, SRKT, Holiday 1, Hoffer Q, and the newer generation ones are the Haigis, Holiday 2, Olsen, and the Barrett Universal 2. So the standard formula, they have easy to calculate alpha, have lots of data because they have been used for the for long duration, and there are various studies that have compared SRK2, SRKT, Hoffer Q, and Holiday 1. So Neely et al. In a study published in 2005, they found that all the 4 formula did not show any significant difference in their predictive error, but Hoffer Q gave a highly variable results compared to the other 3. Now in a study published by Nihalani et al. Showed Hoffer Q to be most reliable and SRK2 to be the least in the population of less than 18 years, where their predictive error was also low compared to the previous study, whereas that subgroup of less than 2 years also showed similar results. Kekuni et al. Published a study in 2012 showed SRK to be the most consistent, whereas the Hoffer Q to be the least predictable. Their age group were less than 2 years, and all the formula had more than 2 diopters of predictive error. Vasavara et al. Published a study in 2016 concluded that SRK-T and Holiday 2 had the least predictive error. Now coming to discussion of the new generation formula, Elbaz et al. In a post published in 2021 that compared Barrett 2, SRK-T, Haigis, Hoffer Q, and Holiday 1 found that Barrett 2 was either superior or comparable to the others, whereas SRK-T was the least predictable. Nackley et al. In 2019 found that the new generation formulas give comparable results to standard IOL formulas in pediatric patient, whereas Epley et al. In 2021 found that the Barrett Universal 2 gave the least predictive error across all biometric features, and SRK-T gave the most amount of errors. So the question is, how much to undercorrect? So there are Dahan's formula where they stated the 20% undercorrection for less than 2 years, 10% for 2 to 8 years. Now another one is the NAD's rule of 7, whereas the target refractive error plus the age in years should be around 7. So if the age is 3 years, so the target hyperopia should be plus 4. Now there's a study published in 2019 by Sir, recommended 20% undercorrection for age less than 3 months, 10% for 3 months to 1 year, 5% for 1 to 2 years, 2% in 2 to 5 years. So what are the problems or the unique situations that we face in the pediatric eyes? So they are the growing eyes. So the question is, how much do we undercorrect? So and another question is whether to emmetropize now or in adulthood. The consensus is almost all of them, almost all of us use undercorrection amount is varying from surgeon to surgeon, although there are surgeons who prefer to emmetropize at the edge when they're doing the surgery, because they feel hyperopia is more amblyogenic than emmetropia, so better to emmetropize now. So, and also the IOL formulas that we use are usually calibrated for the adult eyes. And also the way we measure the axial length and the keratometry in children under anesthesia is not the ideal measuring way that is supposed to be measured, because when we are using the ultrasound, the sound should reflect exactly from the fovea, whereas in children under anesthesia we are not exactly sure whether it is hitting the fovea, so even a little bit around the fovea will give a lot of errors. So the conclusion is no single formula is conclusively proven to be the best. All formulas suffer from various error sources. Younger the patient, higher the sources of the error, and more studies needs to be to establish the accurate pediatric IOL formula. So the recommendation is use the IOL formula which the surgeon feels gives the most predictable outcome as per his experience. Use of personalized A constants, and whenever possible optical measurements of axial length. Thank you.
Thank you, Tanmay. That was a very, very precise talk. We have Dr. Khokar here, and sir has done a very recent, very large study on biometry. So, quick 2 minutes on, or a quick comment on biometry.
Sure. See, when we started doing this cataract 20-25 years back, we also were following the Hans and Pross, and they were doing 20% undercorrection for 10 years, for 1 year and above, which we realized that it was causing leaving hyperopia only. And it was, can I start my next set of slides, please? Can somebody help me here? How do you get out of this? Okay, yeah, got it. So what we did, we took subsets of the patients less than 6 months, 6 months to 1 year, 1 year to 2 years and above. And each subset we put implants in these ones, and we calculated the growth of these patients for 1 year, all these groups. So 6 months went to 1.5 years, and subsequently 1 year went to 2.5 years. And we realized what is the growth which is happening in our setup. Then we realized that we're doing lots of undercorrection, so we reduced the undercorrection. So what we follow for Asian eyes now is, we're doing it for last 5-7 years now. If it's a 5 years, maximum undercorrection do is 2%. We don't need more than, guys at the back, if you're playing games, can you please keep quiet at the end? Thank you. Okay. Second is, if it's 2 years old, you do 5% undercorrection. All right. You can never have a precise lens. The power comes to 22.75. You don't have a lens of 22.75, so you have to decide whether you go 23 or 22.5. So if the kid is younger, less than 5 years, you go a little less. If it's more than 5, you can say emmetropic, I can go either way. So more than 5 years, it doesn't make much difference. And there was a study, I think, in BGO, which was published, in which they did, in 6 years old, they did not do any undercorrection, and they realized that after 3 years, the growth was as good as the normal population. So they never found anything there. So the tricky thing is, between 1 year to 2 years, we do 10%, and less than 1 year, divide into again less than 3 months to 6 months, and 6 months to 1 year. Okay, 6 months to 1 year, it's about 15% undercorrection is good enough in these patients. And less than 6 months, you have 15%, 15 to 20%. Less than 3 months is a tricky business. Now there, the growth is, it happens in spurts. After 6 months, it slows down. So in those patients, you can actually, less than 3 months, if it's bilateral, you can leave them aphakic and come back again maybe a 6 month, 1 year, whenever they feel comfortable. I'm not saying to wait till 5 years, because most of these aphakic patients, once they lose the set of glasses, they might buy one more pair, and that's the end of the story, because most of the parents will not buy them the third pair, especially the kind of background people are coming. So earlier, we were not putting implants in the early, younger age group, but then we realized it's not the age of the patient, it's the health of the eye. If your eye size, say, axial length is more than 17 millimeters, and white-to-white cornea is around more than 9.5, or maybe 10 millimeter and above, you can easily put implants in these ones. So earlier, we were doing this in unilateral cases only. So then we realized what is good for the goose could be good for the gander also. So we started doing for the bilateral cases. And we realized that the glasses and no occlusion treatment required, and they did very well. That's why we found out our formula. And this formula actually works very well with all the Asian eyes. All right, and you've done a good job.
So one quick question.
Sure.
What are your thoughts on the idea of not undercorrecting them because of good refractive surgeries now available, and just concentrating on amblyopia therapy,
Yeah.
and then later doing a refractive procedure in these cases?
Of course, you can do that if you can control the growth of the eye. The problem is nobody can predict what is going to be the growth of the eye. So if they come to myopic, say around -2, 3, 4, you can do it. But if it goes to 16, 17, 18, there's going to be a problem.
Yes.
So I think it's best to kill the thing as you have it. So other thing, what he said is absolutely right. For the patient who can actually come for follow-ups, you can leave him emitropic if the age is maybe more than 2 years. Less than 2 years, we all know the eye is going to grow. So less than 2 years, I will not agree with him. Between the 2 to 5 group, I think I can still go ahead with him and say that you do a less undercorrection. Say maybe a refractive error should be about what, a plus 1 or plus 2. Even that's good enough. If you go for myopia or emetropia in less than 2, they're going to gallop up very high. And that's what doesn't work very well. Okay? And of course, the glasses have to be worn with this subset also. Once you put an implant, undercorrection, you're done to the tune of, say, if you're following Inyadi's rule. In fact, the Inyadi's rule works pretty well. It's better than the Hans and Pross. So it is very close to what we are actually. It was almost similar to that. So we can follow the rule of 7, and the more very high chances that you will not have a problem in this group. Okay?